Thank you very much, Dr. Chauhan sir, for inviting me to be the chairperson of this session. And where BFI is concerned, my only recognition out here is that I am a student of Dr. Chauhan. So that carries through all the time. So today we have a topic to be discussed, which is familial hypercholesterolemia, and what are the modalities which can be used to treat this. This, as the name suggests, is a genetic condition, and the important thing is that if it is not picked up and treated on time, the mortality and the morbidity is very high in the younger age group. And two important points: that if it is underdiagnosed in our country, grossly, because people are not aware, and this needs to be screened very astutely. Secondly, if you pick up one patient of FH, be very sure that you have an access to at least 2 to 5 other patients who are siblings or are cousins of the same, of the particular patient. Treatment remains a challenge, though with newer modalities of statins and the neo PCSK9 inhibitors, etc., which the speaker will be talking about, and multiple other modalities, treatment has become more refined than compared to the earlier years. And I will not be standing between you and the wonderful deliberation that Dr. Viveka has to give out here. Dr. Viveka, as we all know, and has been very beautifully introduced by Dr. Chauhan, is one of the best friends of the group. He is Director Cardiology Pan Max, very close friend, and an astute cardiologist. Over to you, Dr. Viveka, for your introduction.
अभी नहीं
So, good evening, friends. At the outset,
अभी रुक जाओ जस्ट
ये
ये खत्म करके स्लाइड से
kind of introduction. So, but when we look at the, before we started this CME, we had a couple of consultations as well. That what happens if your cholesterol is high, and so not only the physicians, doctors, surgeons, and even doctors at large have recognized that hypercholesterolemia is #1 risk factor for coronary artery disease, so vascular disease. So not only the heart attack, brain, the stroke, and the other vascular diseases are something which is directly proportional to your cholesterol levels. So what happens to the people who have got familial hypercholesterolemia? So it's not just a one entity, there are multiple variables of that, and people who have got homozygous hypercholesterolemia, means that familial hypercholesterolemia, they are at the height, because the number of years the person gets exposed to high cholesterol is the one which decides how much is the risk involved. So if you see the level of cholesterol, if it is high, then number of years which he or she is exposed, that determines the the level of blockage in the heart arteries. So a lot of people would come to me and say that, doctor, I don't smoke, I have not done any sins, then why did I get the cardiac problem? So I always tell, look, the God is very smart, and He has made that nobody lives beyond 100 years of age. So if you are getting heart disease, so if you look at in your society, if you look at in your family, beyond the age of 75 years, the people would go to heaven or hell because of heart attack or brain stroke. And that is a culmination point of atherosclerosis, means the blockage of the heart arteries or the brain arteries. So a stroke and heart attack. So other day, one of my research associates' father, within 30 seconds he died. He was 87 years of age, and she called me, Doc, look, she is a dentist, and she said that, look, my father was absolutely fine. He came from the lift for the lunch, and he sat on the table, and he just collapsed, and he couldn't be revived. The ambulance went there, they couldn't revive. So I said that is what you have to, the smartness of the God's creation, you should understand that beyond the age of 75, if you get these things, then it means that that is the creation. But if it happens at a younger age, it means that that is something which is related to various risk factors. Either you have got diabetes, hypertension, hypercholesterolemia, smoking, stress, and the recent world with COVID and other infections and inflammatory diseases. So if you look at the familial hypercholesterolemia, because if you look at the various risk factors, if your sugar is high, even people who are pre-diabetic, they have got almost 1.5 times more risk of cardiovascular and stroke risk than the people who are non-diabetic. So, and then people who are, so I always tell that there is a data which shows that if your blood pressure is less than 120, then the risk of heart attack is almost 30-40% lesser than people who have got more than 138, 140. It means that the hypercholesterolemia, diabetes and hypertension are a very, very strong risk factor for cardiovascular disease and for that matter for any vascular disease. So if you look at the familial hypercholesterolemia, so any patient who is young comes to us and says that her stress echo is positive, like Dr. Poddar said that one of his known intern, his father was having a stress echo positive. So at an age which is less than 70, 75, there the risk of cardiovascular disease, if it is happening at a younger age, it means that the other variable risk factor has to be there. So if the patient has got high cholesterol, premature atherosclerosis and cholesterol deposition, so no need of cardiovascular risk estimation as they are already at a high risk. So there are surrogate markers of hypercholesterolemia and we will discuss. So first described by Muller in 1939, and if you see this is the patient, index patient here in the photograph, which is 7 years old patient with coronary artery disease. So if you look at the youngest patient who had a bypass surgery done was 11-year-old boy who had a familial hypercholesterolemia. He had a triad of xanthelasma, high cholesterol and premature cardiovascular disease. It means that the cholesterol has got a lot of people, if you see net, there are people who are anti-statin group is there, that it is a toxins, it is promoted by pharma just for the sake of benefit of the commercial benefit and so on and so forth. But if you look at the direct correlation, if you decrease your cholesterol, the risk of cardiovascular disease is significantly lesser. So a lot of people would say that my ex friend is smoking, drinking, doing every bad thing and he doesn't have any problem. But if you look at the family tree, his cholesterol and his father's cholesterol, his mother's cholesterol was very low. So earlier, if it is less than 100 every time, it means that he or she is blessed to have a genetic tree where the coronary artery disease will not be there. But when we see a patient who has xanthelasma and lipid profile shows high cholesterol, then obviously we are worried about the premature cardiovascular disease, and that is something which is the biggest killer because he is the patient who would be at risk of sudden cardiac arrest. So patient who would have a angina pectoris and hereditary xanthomatosis, which is very, very though it's not very common, but definitely we need to look for in young patients with coronary artery disease. So the major defects are low density lipoprotein receptor, and because of this, it's not a very homogeneous group. There are more than 1,000 mutations known. 85% have got a point mutation, 5% has insertion deletion, and 10% would have a splicing. Minor defects will again put them at a high risk. So PCSK9 mutations will also be there, and recessive familial hypercholesterolemia would be there. So they will be having a milder type, but definitely they are at much higher risk of the general population at large. So if you look at the cholesterol deposits, when we see very multiple people, if you recall in your acquaintances, friends, families, you would see that there will be certain people who would have these kind of xanthelasma on the eyes, near the eyes, and then tendon xanthelasma. So that is very specific for familial hypercholesterolemia. So maybe the elbow or the hand would show these kind of things, and then corneal arthritis. So that is very well designed for patients who would have at a young age if they have got. So we need to look at our patients. So if this kind of thing is there, then it means that the familial hypercholesterolemia is something which is a diagnosis without testing anything else. But absence of these signs do not exclude the diagnosis of familial hypercholesterolemia. So if they are there, then without doing a lipid profile, we are very wise that we would say that you would have a coronary artery disease. And let me tell you that we see more and more frequently. I would say that in every week OPD, I would see at least 1 or 2 patients out of 700 patients which I would screen in a week. They would have one or the other form of manifestation. It means that it's not very uncommon. And this is, everybody would know that whose photograph is this, and you see, this is Mona Lisa's photograph, and she had a xanthelasma. That is why she died very young. And if you see her hands, then definitely there was a xanthelasma here as well. It means that it is something which has been recognized very early, and people know that even if you are beautiful, you cannot escape hypercholesterolemia effect. So familial hypercholesterolemia has got a lifetime exposure to cholesterol, and as I said, that the longer the duration of cholesterol, high cholesterol exposure to the body, the more the risk of coronary artery disease would be there. So what we call more than 6,200 milligrams per deciliter threshold of cholesterol per year score, something which is in our common lab test, if the patient has got more than 160 milligram of LDL, it means that that exposure is not good. And if it is there for long term, then the patient would have coronary artery disease. But mind you, if there are patients where the protective cholesterol, that is HDL cholesterol, is higher than more than 45, then it is protective. So total LDL, even if it is higher, but if you have a good HDL more than 45, it means that it is protective and may not harm you as much as people who would have a HDL which is less than 40. It means that Indian subset would, invariably we see that they would have less HDL, and that is why the hypercholesterolemia in presence of low HDL is more harmful. Again, the AIM high trial did show that the artificially raising the HDL cholesterol does not protect. Unlike the artificially lowering the HDL benefits you, but artificially lowering the increasing the HDL does not benefit you. So that is why the niacin and other drugs did not work out. But if you increase your HDL by lifestyle modification, by increasing your exercise, by increasing the intake of walnuts and the almonds, then the increased HDL will protect you. So in fact, one of the great sad stories of cardiology was that the president of American College of Cardiology, who was 59 years of age, he was delivering a talk in American Cardiology, College of Cardiology annual session, and on the dais he suffered an acute myocardial infarction. He did everything right because he had all the data, everything. So when the reporters asked him that what did you do wrong, he said, except for not eating almonds, because I didn't like that, I did everything okay. So it means that it cannot spare even a cardiologist. So it means that you need to correct your LDL, correct your HDL. You have to have a good lifestyle because the other risk factors will also catch up. So cumulative cholesterol exposure is something which is very, very important. So if somebody so we always say that the people, the seeds of blockage or the cholesterol starts in adolescence at the age of 18 to 19. And how does it progress depends on our lifestyle. So coronary artery disease is as much as genetic and these things, but it's also a lifestyle disorder if it happens below the age of 70, 75. And lifestyle means that if somebody has high cholesterol intake, dairy products have been linked. Somebody was telling before we started the session, the high intake of white rice. So there is a study which is called Pure study, which showed that white rice intake increases the risk of atherosclerotic disease by 40%. The wheat intake without unadulterated, so wheat intake increases the risk of cardiovascular disease by almost 37%. That is from cell-inducive data. It means that we need to go back to our olden days and start eating millets rather than the more polished food we take, the more harm it will be. So what does entail in homozygous familial hypercholesterolemia and heterozygous familial hypercholesterolemia? So the cholesterol, if it is high, so obviously the homozygous is much more serious, because here the total cholesterol is going to be in the range of more than 500 vis-a-vis heterozygous familial hypercholesterolemia, where it would be from 350 to 500 milligram per deciliter. So in order to have this high levels, you need to be genetically prone. Whatever Dr. Chauhan gets you to eat, it will not increase your cholesterol to this level. So don't blame Dr. Chauhan that he is getting you fed by chicken and all in cafe and above. It is something which is genetic. So two major genetic defects in LDL metabolism, tendon and cutaneous. Cutaneous, the xanthelasma often before the age of 10 years, so meaning thereby that they start right after the birth and they will be having very high levels of cholesterol, and obviously it takes 7, 8 years or 10 years of high cholesterol to get into this. And it is not only the coronary artery disease, the cerebrovascular disease, but also there is significant aortic stenosis. So there is a direct correlation between the high cholesterol and the valvular disease, which is stenosis of the aortic valve. So the patients who would have a familial homozygous familial hypercholesterolemia, they might have a coronary artery disease in less than 25 years of age. Those who have got heterozygous, they might have onset between 30 to 60 years. In fact, we have around 7 patients who have the same date at the age of 41 years of age. The father had an acute myocardial infarction, and the same age, the son also had an acute myocardial infarction. It means that the genetic predisposition is very, very important in this factor. So we need to start the treatment at a very young age, not only the lifestyle modification, but these are the patients where the pharmacological intervention is also required. So in most of the countries, the diagnosis of familial hypercholesterolemia is very low compared to estimated prevalence. Now we have got various labs, even in Max, we have got genetic testing for familial hypercholesterolemia and all. If you look at the country as advanced as USA, the people are treating the end stage of the disease, that is doing a primary PCA and intervention and putting stents. But if you look at the early diagnosis, in Netherlands is the one which is way ahead. So all these Scandinavian countries, and including the United Kingdom, the genetic diagnosis and early diagnosis of this is very, very important. So if you look at the familial hypercholesterolemia, this is a global arm, called to the arm. So we need to do the screening, increasing the awareness in early diagnosis and early treatment. So family history is something which is very important. It's not just the immediate family. We need to look at the 1 or 2 generations back. We need to look at the history of young deaths, acute myocardial infarction, and people are now looking at these things. So it is something which is preventable, and this is treatable as well. So we need to, something we need to invest into this, and find out the history of the patient's family as well. So if you look at the history of familial hypercholesterolemia, it is according to the EAS consensus panel statement. So there are various criteria for diagnosis of homozygous familial hypercholesterolemia. There is a genetic confirmation of 2 mutant alleles. So basically, this is done by the blood test, and we have got various companies. Turnaround time for these tests are around a couple of weeks. So within 2 weeks, you will get all the information. So I always, so there are people who have had a, coronary artery disease at the age less than 40 years. We tell that, okay, you need to get the, your children's genetic profiling, and then find it out. There are the genetic predisposing factors for this. So if you see that the total cholesterol is more than 500 or even more than 300, we need to be really, raising the alarm, and we need to find out whether this patient or the person has got a familial hypercholesterolemia. And invariably, if you ask them, they will say that, the father or father-in-law died at a very young age, mother or somebody in the family would die because of coronary artery disease. And increasingly now people are more aware, and if you look at that, and then the good thing is that direct intervention by reducing the cholesterol levels would, give you the dividends. So there are various criteria for diagnosis of heterozygous familial hypercholesterolemia, but we need to have part of the genetic marker. There are now markers which can provide you the information that who is the patient who would have a high risk of coronary artery disease in less than 50 years of age group, and the diagnosis of familial hypercholesterolemia in children and adolescents. So that is the reason, and the best thing with these tests is that you can diagnose them very young before the disease has manifested, and it can prevent them as well. So it is definitely a very, very underdiagnosed entity, because the 85% of the predicted are missed diagnosis, because diagnosis is not missed, because by the time people feel that coronary artery disease is a disease of older age, so they don't invest in younger age, then people will say, when they say that we are going old, they will say that, once I've got 40, now the society will say that new 40 is 70 or 60, so people don't really get the test done. But we need to make them aware that the high cholesterol level for very long would lead to these things. So it is something which is a progressive and burdensome thing. So if we can cut down on the total cholesterol level at a very young age, less than 30 years of age, then the cumulative exposure of these high cholesterol, if you can decrease the risk of coronary artery disease, would significantly be brought down. So we need to screen them. So when do we screen? So obviously, if we have got parents having coronary artery disease at a younger age, if we find the cholesterol at random, so now the schools have also started doing the preventive health checks, and we find that the cholesterol levels are high, then the mean levels, then we need to be really getting the alarms done, and then we need to check it further and check it whether it is really familial hypercholesterolemia, homozygous or heterozygous. So what are the, clinically you can see though they are very uncommon, but if they are there, it means that the things are very, very significant, like tendon xanthal asthma, tuberous xanthal asthma, arcus, which is in the cornea, and then these are patients where the cholesterol response to this statin may not be as much as desired. So they'll never ever achieve the desired cholesterol level, so statins will not reach the target. So we always cry about that when you give the cholesterol, statin therapy, many patients do not reach the targets, and when you give the oral therapy, they will not reach. But now, fortunately, we have got PCSK9 inhibitor, we have the what we call the also the other therapies which are short for 6 months. We can give Cibrava and all, which is again the at the receptor they work. But in patients who are really not responding to all of them, then we need to give therapies like apheresis, and liver transplant could also be thought of. We had one patient who had operated for bypass surgery at the age of 14. So you can imagine, and the grafts got occluded at the age of 22. So it means that it is a very, very malignant disease. So we need to identify them. 25 cases first. Less than 25% of the cases are identified. And there are other causes of premature myocardial infarction like raised LDL cholesterol, so on and so forth. But these surrogate markers, if they are present, then we need to really work on them. And this is something where lipid deposits at the 4 years of age, you can see that these xanthal asthmas and the tendon lipid deposition and all are there. So definitely these are the things. They die very young at the age of 14 years of age. Apheresis was started, and 22 years of age, the patient died of aortic stenosis. Because even if you change the valve, the patient should have recurrence of aortic stenosis, and also they would have all the manifestation of deposition of high cholesterol in these patients. There is 5 times faster increase of, so that is why after this study, the intima media thickness became a standard of investigation, where we would see that the surrogate marker of cholesterol deposition in the arteries is, carotid intima media thickness, whereby we can find out whether the patient had deposition of, these cholesterol in the endothelium. So familial hypercholesterolemia, the effective therapy is to lower the LDL cholesterol burden. And how do we lower? We need to lower it with a high statins. So this is regression. So there are only rosuvastatin has shown to regress to some extent the plaque which has already formed. So we always say that if you had increase your weight, if you have belly fat, not even if you have lost your 30-40 kilograms of weight, the cholesterol deposition may not go down, and so don't allow the cholesterol deposition in endothelium. Then we can give obviously the high intensity statin. We can add on ezetimibe. PCSK9 inhibitor is something which is really good. Then we can think of FLSs and so on and so forth. So NICE guideline also says the same thing, that we need to decrease the LDL cholesterol from the baseline more than 50% of the baseline, and LDL cholesterol less than 50. Rosuvastatin should be started at a very high dose, and ezetimibe combination with statin. So mainly whatever you have to decrease the cholesterol, that should be given apart from a very good and robust lifestyle. So risk of coronary artery disease in familial hypercholesterolemia is really very high. Odds ratio is again very significant. The treatment of familial hypercholesterolemia is statin, and rosuvastatin is the most powerful statin, but you can combine it with the other modalities. And now we have got a receptor blockers, we can go with the PCSK9 inhibitor or even the Ciprava. So if you look at the comparison of rosuvastatin versus other statins, only rosuvastatin has got a more robust decrease in total cholesterol and LDL cholesterol per se compared to the other statins, especially the atorvastatin and all. So these are the data which shows that efficacy of rosuvastatin in children with homozygous hypercholesterolemia and associated with underlying genetic mutation. The LDL cholesterol decrease is significantly more with the rosuvastatin compared to the other statins. PCSK9 inhibitor, I think this is very expensive therapy. So one injection would cost around $22,000 in India, but around $20,000 in US. But definitely it is worth it in these conditions. So to conclude, I would say, friends, that the screening will find patients with genetic hyperlipidemia. Familial hypercholesterolemia is at least 1 in 500 UK population. This is the Uttarakhand population, I would say. Family cascade screening is required. So anyone who has got a young coronary artery disease, we need to screen the whole families, and then statin treatment. And more than that, we need to look at the, once we diagnose familial hypercholesterolemia, we need to go beyond that, and then these, receptor blockers like either PCSK9 inhibitor or Ciprava, these are the things, glycerin, these are the things which will decrease the cholesterol to substantial level, and that will decrease the burden of coronary artery disease.
Very good.
Thank you very much.
Thank you, Dr. Viveka. So before I open it for discussion on the forum, a few quick questions. So in your experience, what is the average longevity that you have seen for a patient of FH? Heterozygous or homozygous?
So I think homozygous, we know that they would be, so if you look at the average longevity is less than quarter century, so less than 25 years of age, they would have better outcome. Those who are heterozygous, they might go into 50 years of age and then they will die.
So whatever the international statistics are, that is the same observation that we get to see out here.
Yes, I think
because we are seeing people with comorbidities and early diabetes and other things. So does that compound your problems, or it's something which is similar to in terms of this alone in statistics worldwide?
No, so in our country, other risk factors are also exorbitantly high. If you look at the pollution, the diet, diabetes, hypertension, these are much more multifold. I would say that we see, and then the sensitivity to diagnose the familial hypercholesterolemia in our country has just come up. I would say that even the acceptance of high dose statin is very, very low. I would say that I have seen at least more than 100 occasions where we have started this statin therapy in younger population. At the age of 20, this is too aggressive. You should not do this and that. And then within a year, the patient, I still remember there are 2 patients of family who are from Viveka. At the age of 21 and 27, they had acute myocardial infarction, diffuse disease, and then the cardiologist at their local center, so-called cardiologist, they said that who starts this statin therapy at this young tender age. So you can imagine the sensitivity and awareness about these things are very, very low. So you'll get opposition, but I would say that these things, and then today, you must have seen that Supreme Court has also rubbed our yoga guru there, because he's treating good with these things. So very good. I would say that these are things which the society, and it's a very good lesson for the society that the medical disease should be treated by the qualified doctors rather than somebody who is
very true, sir. Thank you so much. On what level if a patient is coming to you who's already on statin therapy, and if you have a suspicion for FH, heterozygous or homozygous, what is the, by and large, the average level that you're looking at before you start thinking about it, or do you subject that particular patient to some kind of a genetic testing or otherwise? Some format of
yeah, so I think
that you're
we
looking
see
at.
that if the total cholesterol is more than 350, then the heterozygous, so 350 to 500.
On statin, otherwise, some
no otherwise.
Okay.
And if the patient has a naive patient who has come to you, if the total cholesterol is more than 500, then we need to think of homozygous familial hypercholesterolemia has to be ruled out. I mean, it's between 350 to 500. It has to be heterozygous. So I would not name, but there are a couple of 2 physicians from Delhi Medical Association who started very young. They had LDL cholesterol, the total cholesterol was 300, LDL cholesterol was 190. And it was blamed on the dietary things that they are eating, and both of them were medicos, and they were having these.
So if the information or the disinformation is to that extent with the medical fraternity, I shudder to think what about.
So basically, the acceptance is not there, and then we got the genetic testing done, and we proved that the patient, the person in question had familial hypercholesterolemia, and now on injectable, inclisiran. Unfortunately, when we diagnosed, we had inclisiran available, though the cost is almost 1 lakh in 6 months. So my
cardiologist rather than afford that.
Yeah. So, but obviously the cholesterol, we brought it down, and the LDL cholesterol could be brought down to less than 100. True.
Thank you. CSI 2023 brought out a position statement on the treatment of dyslipidemia with special reference to the FH. And I had the good fortune of listening to that. So, by and large, agreeing with this, whatever you have said. But how often do you see a patient of yours who has to undergo apheresis, you mentioned as one of the treatments, or even liver transplant as one of the. Have you actually had a patient who has had to undergo this, or?
So not
by
entirely.
and large?
So these are the data from before we had availability of high intensity statin, especially when the atorvastatin was just coming in. So once the atorva and rosuvastatin has come, so rosuvastatin, I would say that in combination with the bempedoic acid and the azithromycin has done the trick, but the availability of PCSK9 inhibitor and inclisiran has really created the need. So I have not had any patient who went for apheresis.
I mean, I can very well understand that compliance remains a problem, because like you said, if the cardiologist was hesitant to understand and to initiate his sons on treatment. I mean, what to talk about the general public. So thank you very much for your input, sir. I will hand it over to for the questions to
Dr. Viveka sir has a question.
Very good. Sir, after this, sir, any cutoff for the LDL cholesterol for diagnosing familial hypercholesterolemia? LDL cholesterol. You talked about the total one.
So LDL cholesterol without medication and all, more than 180, then you need to.
More than 180.
So it is not the LDL alone, it is the combination of total cholesterol plus LDL more than 180.
And what is the state of bempedoic acid as a add-on for the statins?
Yes, so now we have got the good data that bempedoic acid. So initially we were saying that except for statins, there is no other drug which has decreased the event rates, though they decrease the total cholesterol and LDL cholesterol. But now we have got a positive data with bempedoic acid that stand alone, those who cannot tolerate statin, bempedoic acid can decrease not only the cholesterol but also the event rates. So we can, for those people who cannot tolerate the highest possible dose of statin, or those where we are not reaching the target, we can combine. So I think the rosuvastatin with bempedoic acid, it comes in the brand name of Rosuvas B, which comes in 40 plus 180 milligram for bempedoic acid. That has shown standalone bempedoic acid can decrease the event rate. Even in pure data, we have seen that acetamide can decrease the event rate. So now proven data shows that though the decrease in event is not as robust as with statin alone, but definitely it is worth it.
Very good. Dr. Amish Vora has a question.
Sir, विवेका सर को देखते ही क्वेश्चन आ सकते हैं. Sir, quick two questions. One, and how the journey. So one of my patient who was on chemotherapy had triglyceride of 1,200. I had never seen this type of report. Then I entered into the history, and I found that Asians have, especially the Indians, North Indians, have a familial hypertriglyceridemia. And I think FH means only LDL, what I understood from your lecture. Where does this familial hypertriglyceridemia come into the picture? After that patient, I started looking at all my family relatives. Everybody's triglyceride was a good healthy diet was around 400 to 500. So that was one question which I had. Second question, sir, I had was, you gave the two indications of homozygous and heterozygous. One is genetic testing, one is clinical stigmata. If both are equally good, do we really require a genetic testing? Because if there's xanthomas and other clinical stigmata are there and LDL level is there, isn't that sufficient? Do we really have to prove with genetic testing?
Yes, I think that's a very good question. So if you look at the familial hypertriglyceridemia, we had patients, so you have in the range of 1,000. I had the director head of MMTC whose triglyceride was in the range of 3,000. So we have icosapentatriene medicine which is specifically meant to decrease the triglyceride, but you're right that in certain patients it doesn't go. So we have got the metabolic thing, sanoglitazole like lipaglipron, which decreases the triglyceride level significantly. But the familial ones, initially, if you look at the ACC/HA guideline and ESC guideline, LDL was considered to be directly correlated with the coronary artery disease. And then there was a very famous paper from Indian American Dr. Inas was a Keralite who showed that in South Asians, the triglyceride is very important risk factor. So high triglyceride is a very important risk factor for coronary artery disease. And in fact, it is shown that the reversal of plaques, if you look at the reduced heat trial, that showed that with the decrement of triglyceride to less than 150, you may get plaque reduction, the plaque volume reduction, and that was with icosapentatriene molecule. So coming to Dr. Amish's question, that you need to know. So we have seen that there are many people who are very. So if you take very rich carbohydrate diet, if you have taken something which causes the very sudden rise, so things which are very, very high in, absorbable sugar like glucon-D, so that can certainly increase the triglyceride level. So, but triglyceride is not an innocent bystander that can cause coronary artery disease and soft plaques, and especially in South Asian population is a risk factor for acute myocardial infarction as well. So we need to do the genetic testing, that it is genetics or the diet alone or the lifestyle modification. So we need to prove that. So I think we need to do the genetic testing. And since we have got the access to genetic testing, why not use it and know that? So definitely if you know that the X person is prone to have a hypertriglyceridemia, at least we can say that, look, you should not be eating this. You should be just eating a very, high, low glycemic index food so that you are protected.
Just to put the record straight, sir, like Dr. Amish also asked, and otherwise, if the basic other lipid profile parameters are reasonable, within range, do you need to chase the triglycerides beyond 400, or there was something that you need not do it unless a patient is at risk of pancreatitis with other problems?
Yeah, so I think if you look at the data, more than 250 milligrams of triglycerides, they are a standalone risk factor. Even if the LDL is okay, they are standalone risk factors. So not only for coronary artery disease, or atherosclerosis, but more so directly correlated with acute myocardial infarction, because that makes the blood more, what called viscous, and that would cause more myocardial infarction. So the triglyceride level and acute myocardial infarction. So you will be surprised to know that South Asian population, Bangladesh, Sri Lanka, India, Pakistan, not Afghanistan, they are at the highest risk of acute myocardial infarction in age less than 50 years of age. So, and then if you look at the coronary studies, CT coronary angiogram correlation study, that showed that more than 60% of them did not have atherosclerotic blockage on CT coronary angiogram or conventional angiogram more than 50%. So less than 50% attributed to more than 90% of acute myocardial infarction. I would say that yes, we need to decrease the triglyceride and LDL, and definitely in Indian subsets or South Asian subset, triglyceride is very, very important subset to play.
Totally agree, sir. Also, we need to put it forward for the general public out there. It's the high carbohydrate diet which is the killer. Not, we don't eat fats to that extent. It's the high carb diet which is the killer, which is going to lead to all kinds of alteration in the lipid profile.
Dr. Ashok Chakraborty has a question.
Thank you, Dr. Sushil. Good evening, Dr. Viveka. Excellent talk. I'm one of those proud pediatricians who have joined the PFI of late, and I'm greatly enlightened by the diversity of medical knowledge that's getting into my mind. Being a pediatrician, I know that we rarely get cholesterol done, except in nephrotic syndrome, and we find the levels of cholesterol. But what I have learned of late in the last few meetings, and of course the DMA annual function, is that each one of us, after the age of 50 years, has got a plaque. Dr. Prem mentioned that. So, keeping in with you this thing, should we also get anti-plaque measures, besides lifestyle management, of course, like Dr. said, carbohydrates are the killers. Should we all start taking statins? That's my question. Because somebody says take it, somebody says no, don't take it. Should I go for genetic testing? Should I go for my LDL levels? What should be the case?
Before Dr. Cmes answers, we go back to your good old days of Robbins, Cotton and Pomaco pathology.
Right.
The plaque situation starts off in the body by the age of 12 to 13 in everyone.
Right.
Is the streak which starts off. How it progresses defines the clinical
Genetic.
Yeah.
So coming to Dr. Chakraborty's question, I would say that I still remember whether Dr. Chauhan remembers or not. In one of the first CMEs which we did on statins more than a decade back, I said that the government of India should start apart from chlorine, they should have statin also in the So it means that adding the statin would decrease the risk of cardiovascular disease definitely. And then it has been seen that there are a lot of people who would take it and I don't know whether there was one doctor in the group, very senior doctor. He said that I have been taking 5 milligram of statin alternate day for last 10 years, and my SBL has gone up, LDL is in the ring, and the risk of, so now he is reached age of 78 years of age. I won't name him, but definitely there are people who have benefited from statins. So answering you that apart from good lifestyle, the statins would also, why does it help is not only the total cholesterol level goes down, but also the robustness of the plaque. So what we call, when we do the optic coherence tomography when we do the angiogram or angioplasty, which is called OCT, the people who are on statins, high dose statins, there they do not have thin cap plaque. Thin cap plaque means they are vulnerable plaque and can cause acute myocardial infarction. The statins makes the plaque more fibrotic, so it becomes thick cap plaque, and definitely the risk of heart attack and acute myocardial infarction is significantly lesser. So the answer is that yes, you should be taking.
Thank you so much, sir.
Sir, we have the President of the Nutrition Society of India.
Yes.
And so much of talk about high carb and high fat diet. And he would like to collaborate with you actually. Sir.
Yeah, Dr. Sharad.
Yeah, he likes to collaborate with you on a long-term study. But for the time being, he has a simple question, sir.
Thank you, Dr. Sushil. My question is, as a pediatric gastroenterologist, currently I am having a patient referred to me by the Middle East, the North Middle East, quite far away from our country. And this kid is 2.5 years old. Actually, this is the second case of type 4 hypertriglyceridemia, which I have encountered in about 30 years of clinical practice. The first one was about 18 years ago. This kid has a triglyceride of 280. The kid is 2.5 years old. Triglyceride of 280 and cholesterol of 280 and triglyceride of 5091. 5091. So I have involved the dietitian and we have given a diet. We have involved the pediatric cardiologist. We have involved the pediatric endocrinologist. The child had a very bad pancreatitis. That's how I came into the picture. With a lipase of 1500 and an amylase of 2000, which has now come down to 61 lipase and amylase of 39, which is normal. Lipase is borderline elevated. So my job is over as a pediatric gastroenterologist. Now the family keep repeatedly asking me what to do. So my pediatric cardiologist, who is a batchmate of mine, has said, this child will only benefit from a liver transplantation. You do whatever you want in diet, nothing is going to work. This child needs a liver transplantation. What I want to understand is, how will a liver transplantation help in this situation? Are the indications for adults and children different? And what is the life expectancy? Because without a liver transplant, how long will this 2.5-year-old child survive? That's what I mean.
Yes, I think that's a brilliant question. So we had, for last 1 year, we have a new injectable molecule to decrease the triglycerides. In fact, we are one of the global centers for this investigation.
This child received Rosuvas for the past 4 months, 10 milligram once a day.
No, so it's not.
And then the triglycerides have gone up from 1500 to 5000.
Yeah, so that's what I'm saying, that this trial is, there is an injectable once in 3 months injection, which is again something like a PCSK9 inhibitor. So we have reserved that with the oral therapy, if the triglyceride does not go below 500, then we have to still, and we have got, so I think now.
Is it safe in a 2-year-old child?
Yeah, 2 years old. Yeah, so in child also, in adults also, so anyone who meets this criteria. So this is something where the liver receptor is at fault. So that is why the cardiologist says that liver transplant would be handy, because if you either block the receptor or you transplant. So till now we did not have access to this molecule. But now this molecule is available, and right now commercially not available in India, but we can include him in this trial. or we can, do the liver transplant. But we know that the morbidity of liver transplant is very high, so better to give this molecule injectable once in 3 months, which is much better.
So, what is your advice? At what age, first time a child should undergo a clinical bypass? In the school time?
Yeah, so I think the school time once.
At least once.
So the dictum of preschool health checkup is very, very important. The moment they go to nursery, there is always a test and all is done. But definitely we need to look at the family tree, those who are at a higher risk and all. Both parents have coronary artery disease or even at a young age. Then we need to do that. But preschool test is very important.
Sir, a wonderful talk as always. My question was almost what Dr. Podar just asked. When we have a patient of familial hypercholesterolemia, at what age we should start the screening process, and if found abnormal levels, how early can we start statins?
No, so that's what we were discussing with Dr. S Sengupta, that people felt that you should not be starting statin at the age less than 40 years of age, but now we need to see what is the the status of these patients. So if the patient has got a very strong, so motivation has to come, that if the family is very strong, people are dying young, have a very young coronary disease, then those the parents who are motivated, that look, doctor, my husband had this or my son had this and I don't want my child to have this at a young age. So they are the ones who are forthcoming, the data which has come from them. So we need to look at the preschool and then pre-college lipid profile, because these are the things which start very young. And then those who have got a surrogate marker, so suppose a familial hypercholesterolemia even at the age of 8 to 9 years would have something, genital asthma, and then they would have tendon deposits and then corneal deposits, and also these two things in regular health check will be picked up. So if you look at the healthcare burden, if we start looking for everybody, then obviously the sky is the limit, and then obviously our healthcare will not able to sustain that. So we need to look at the family history, we need to look at the surrogate markers, and if they are positive. So the standard of care is that, okay, look at the, at the age of college going, or when you get into college or medical school and all, before that there is always a health check. And if you pick up normal things, then we need to work on that.
Yeah, precisely, sir, because when we are having MIs at the age of 25, we can't wait till 40 to start the statins. Thank you, sir.
Dr. Bimal has a question.
I would just like to add one very small caveat to what sir has already said. We are talking about triglycerides, as sir mentioned, and otherwise 5,000, 4,000, and the risk of side effects of a drug. The risk of a side effects of a drug come in when we are trying, otherwise the bacha won't survive. If you have a dead bacha, what do you do? So I think it's a better trade-off to have a kid, try out a drug, and titrate the side effects, whatever the case might be. If you don't have the child living with you, what if the discussion ends to nothing?
No, so I think just to add on that we now have got into the specific receptor blockers, and the gene therapy has come in a big way. So now these are the situations where the gene therapy is very, very successful. So this is going to be the future. So the moment we diagnose, we do a gene mapping, we do a genetic test. So somebody was asking that, is it, I think Dr. Vora was asking that, is it worth doing a gene testing? Answer is yes. But then you can do a gene therapy and things will be treated completely.
Dr. Bimal,
coming to Dr. Sarath Gopalan's question, who should be the donor, from where we should do transplant for the baby? Could Dr. Sarath Gopalan
Yes, I think we need
Did
to.
the father or mother or...
So they should be genetically tested. So those who do not have abnormal liver, obviously they have to donate. But obviously we need to look into normal lower liver donor. So there are liver donation and thing is a different altogether different chapter. We'll have some meeting.
I think once you donate liver, it can regenerate within few months, so there is no harm if parents can do
Absolutely. But I think with the current standard, availability of gene testing receptor blockers and all, then it's not required.
Sir, wonderful lecture and wonderful answering. And before we move to Dr. Tulsi and Dr. Amal Kalda, sir, just few simple questions, sir. So usually we target LDL cholesterol in the classical hypercholesterolemia scenario. Sir, in familial hypercholesterolemia, which is, there are multiple things that you are targeting. You are targeting LDL cholesterol. You are also targeting hypertriglyceridemia, as you just mentioned. So beyond targeting LDL cholesterol, what benefits would you achieve by targeting hypertriglyceridemia apart from maybe preventing pancreatitis? Any other benefits? Or is that also an atherogenic molecule beyond LDL?
So that's what I was saying, that the data from INAS did show that in South Asians it's an independent risk factor for coronary artery disease, and more so for acute myocardial infarction. So definitely we are not treating for for pancreatitis at all. We are treating for the coronary event. And then the HDL level also. So when you look at when we started reaching these patients into a target range of LDL, we still had a lot of coronary events. So we said the new term which is called residual risk. So residual risk is that even if you have achieved the target of LDL, still a lot of people who are having coronary events, which means that something else we are missing, and that something else includes triglyceride and HDL. So obviously, then we went beyond that. We went that there are certain genetic markers like lipoprotein little a, lipoprotein little b. So these are the things which have been shown to again contribute to the coronary artery disease. So these are things has to be targeted. So if you look at the PCSK9 inhibitor, it not only decreases the LDL cholesterol, triglyceride, but it is the only molecule which decreases the lipoprotein little a, which is a genetically determined risk factor. It doesn't come down to statins and all. So I think this is something which is that is the reason why the PCSK9 inhibitor injection is very,
Sir, do you have a patient of FH where you are treating him with rosuvastatin, treating him with PCSK inhibitor, treating him with bempedoic acid, and also treating him with ezetimibe? All the 4 drugs.
Yes, I think I would. So before we had the access to, so in fact, these all, except for the statin, these 3 things came in a crop, so they came within a year or 2. So, but before that we were using high-dose statins alone. Then the pomalidomide is the old thing, but the positive data came just during the COVID time. So we have few patients where we are, so those who have advised PCSK9 inhibitor, they said it is very costly. Why don't you put it on oral medication? So then there are, quite a few patients where we have given statin plus ezetimibe plus bempedoic acid.
Dr. Tulsi, sir.
Is there anything more left? Except for the dinner.
So let me say, Dr. Viveka, what a wonderful talk as usual, and so well moderated by Dr. Sengupta. So you talked about familial hypercholesterolemia, especially the homozygous and the heterozygous FH. What about the syndrome of the FDP, which is the familial defective FOP100? So how do you distinguish the FDP from the heterozygous familial hypercholesterolemia? Would you say the LDL receptor analysis probably would confirm this? What do you say, sir?
Yes, I think that's something which is very good point you have brought in. So these are the genetic risk factors for coronary artery disease, and unfortunately in Indian and South Asian patients this syndrome is much more common. So if you look at the familial FOA syndrome, which is very common, and then other problem with this is that it does not go down with the statin. So lipoprotein little a will go down only with the PCSK9 inhibitors. So it is very important to classify them, that is it the familial hypercholesterolemia or the other syndrome whereby so the benefit of using statin and these receptor blockers is very, very important.
Right. So incidence, you say probably 1 in 200 to 250 persons, which is about twofold higher than what we thought previously. Is the incidence higher in Southeast Asians as compared to the Western populations?
Yeah, if you look at the data from UK NICE guideline and the data they received, it was 1 in 500. But if you look at the South Asian data, that is 1 in 250. So it means that our population has got a high incidence.
So the onset of symptoms in women, see, we have women here, the lady doctors here. So lags behind by 10 to 15. I talked about the CSI 2023. Let's dwell a little on the ACC 2024, April 6 to 8 at Atlanta. Were you there, sir?
No.
Okay. So 3 lag breaking trials, especially on lipid management, were presented, and they talked about bridge Cmes, ApoC3 inhibitor, which is the olezarsen, reduction of triglycerides. If they are more than 500, this was a landmark trial.
Yeah, so I think that is what I was talking about, that we were also one of the centers for this olezarsen, and we could get only 3 patients because the patient did not consent that they want to take the, even if they did not consent for the participation.
Okay, that's okay. That's very interesting. What about the Victorian Initiate trial on inclisiran, which is a gene silencing drug?
Yeah, so I think again for the Victoria Plan study, we are one of the nodal centers. We have included around 12 patients for that, and that is what I was talking about. That this is once in 6 months injection, and inclisiran is shown to be even more robust than the PCSK9 inhibitor, and it not only decreases the total cholesterol, LDL cholesterol, but also triglyceride and lipoprotein, which is something one shot does the job for everything.
And just twice a year.
Twice a year.
Wonderful, sir. The third landmark trial was among the Liberate trial, which is the Liberate on PCS, which is the PCSK9 inhibitor, lowering lipoprotein little a. Dr. Manish, where are you? He is very fond of lipoprotein little a. So it reduces lipoprotein little a and LDL to a greater extent.
Yeah.
The Liberate trial, sir.
So I think if you see the Indian subset, lipoprotein little a is considered to be a very high risk factor in India, and it's a genetically predicted rate. And PCSK9 inhibitor is the only molecule which will decrease the lipoprotein.
Wonderful, sir. Thank you.
Sir, just only few comments. I think 9 to 11 years should be accepted as the child screening for cholesterol, even healthy.
Yeah.
Because we are now more concerned. 9 to 11 years. Once to start with. Sir, to add to Dr. Tulsi, so many studies.
Just 3 studies at the same time.
Yeah, CETP inhibitors. They are coming in a big way. They will increase HDL by 165%. Decrease LDL by 50%. They will also decrease LP little a, the favorite of Dr. Tulsi and Dr. Yanash, by 50%. So they are coming in a big way.
CETP inhibitors.
Viveka beautiful. No, sir, they postponed. It was to be.
कैब वाली सी कैब से भी स्टार्ट हो गई आपके कैब से
Beautiful Mona Lisa, I think, was suffering from hypothyroid also. It was a bit evident from her eye growth. So I think liver transplant versus gene therapy. Gene therapy will score much more because whatever liver you give, the genes are there. So we have to change the genes. So that will be even better.
The liver transplant is two extreme steps. Gene therapy is the future.
I think, friends, we had a wonderful session, and I would request Dr. Sen to just summarize it in 1 minute, the entire beautiful, wonderful CME by Dr. Viveka, what is the carry-home message for physicians and our GP friends?
Few simple lines: detect early, have a clear clinical suspicion, treat intensively and early, and hope for the best.
Very nice.
Thank you very much, Dr. Sen, and thank you very much, Dr. Viveka, sir. I would request Dr. Viveka and Dr. Sen to come here so that we